So I'm actually going to get the jump on it by a minute or so. This is going to be a packed and dynamic panel. This is where we turn the corner. I would characterize the rest of the day as being marvelous and wonderful examples. And as Dan Fox once told me, it's nothing without changing the power dynamics. You have to think about where the power lies, what the policies are, what the structures are. Why is it that we have nearly 100 examples of social determinants of health being effective in advanced illness and essentially none of them being sustainable and spreadable? Why is it that PACE is 40,000 people? Why is it that things are not only bad, but due to get worse? Why is it that we are learning to ignore that fact rather than learning to confront it? This is the panel at which we take up policy possibilities, action steps. Enough of these nouns and verbs and periods. This is the time for exclamation points. This is the time for fear and frustration and disdain and anger and productive steps forward. We must leave here with the ideas that might carry forward. And by damn, I'm glad for Gwen saying to write to Seema Verma. We need to start pushing at that level. We need real political push. Who is it who speaks up for these issues? Is it pharma with their $10,000 in walking money on the Hill? Is it the big health plans? Is it the politicians who can manage to have spent the last 10 years debating Medicare coverage and coverage of people for medical care issues, but not anything about supportive services? So this panel has had a couple of rounds of conversation and emails, and we want to start off with some kind of basic claims that were just indisputable, but important context for this country at this time. So the first is that the services are already inadequate, unplanned, unreliable, and due to get worse. Whatever problems we have now are going to be much worse when we double the number of people in just the next 15 years. All those kiddies that Life magazine was so proud of putting on the cover in 1955 as they trundled off to elementary school are now with me growing old. And unlike what happened in 1965 when Medicare passed, we forget that when Medicare passed, the average age of death was still under 70. The usual causes of death were heart attacks, strokes, and infections, rapid killers. We now have an average of 2 years of self-care disability at the end of our lives. 40% of us will have cognitive failure if we make it to 80. We have not made plans for this, even though this was entirely predictable. Unless some plague comes along that somehow kills off all of us 70 and up, we are facing a major social disruption. When I was growing up, almost everybody who retired had already burned their mortgage. They had a house. Almost everybody who retired had a pension on top of their Social Security. 50% of people now at the time of retirement have no income but Social Security. How are they possibly going to deal with what they need through 20 years, 30 years of retirement, and then bad illness? We have done so little to prepare for what is coming at us, and we could still do it if we start today. If we wait till 2035, we're sunk. We're going to learn to walk away from people in the way we did in the past. And if you don't remember the past, remember in 1978, when I first served a nursing home, there were whole states where half of the people were tied down and sedated. There were whole nursing homes in this city that had half of the patients with stage 3 and 4 pressure ulcers. We have come some distance. We stand to lose it all. Those weren't awful people doing that. Those were people who had no resources and no training. So We're already inadequate, unplanned, unreliable. And where's the political will to fix that? Where's the push? We are already seriously underfinanced, both private and public. And in order to get through the aging of America, it has to be both private and public funding. If we wait and pretend we're somehow going to take it all out of public funding, good luck with that. That's not only politically implausible, but an enormous degradation of the economic life of the country. It has to be both vibrant in investment opportunities by having savings in substantial amounts and having better taxes. We are limited by an underpaid, underskilled workforce in all positions, not just the home health aides who get essentially no training and no career ladders, but even at the very well-paid doctor end. How many primary care doctors know the least thing about fitting a cane, about how to deal with the change in the distribution of the drug in the body of a 90-year-old? You know, the basics of geriatric care are not even being taught in our medical schools or in our training programs. So all the way across the whole workforce spectrum, we have people underpaid, underskilled in a workforce that is inadequate, and we're going to cut immigration? Right. Who's going to spoon feed us boomers in old age when we only had 2 kids and they live across the country and we don't have an immigrant labor force? You got to be kidding. It's going to be a robot? Good luck with that. So the whole issue is avoided and misunderstood by leadership and by the public, so that we don't know how to even bring up these issues in a public forum. We don't know how to talk to congressmen about the issues of caregiving. We don't know how to get leadership willing to do anything substantial or even to deal with this. This is one of the many black holes of policy. Research shows quality and cost gains with all kinds of interventions. You've seen some wonderful examples here today. We do not have a dearth of possibilities. We have a dearth of will. We do not have a dearth of possibilities. We know a lot about what would work. What we don't know is how to get there. So we also have many examples of good comprehensive care at small scale. Every community I go into, there is someone doing it right. It might be a PACE program. It might be a little geriatrics program. It might just be Dr. Smith off in the corner managing to do it against all forces against him. I went to a nursing home once in New York City. They sent almost no one back to the hospital after the first couple of weeks. I said, why do you do that? Everybody else is bouncing people back to the hospital, making a whole lot of money. He said, because hospitals don't do well with our patients. They come back with skin tears, and they come back with confusion, and they come back with chaotic medications, and they're scared as hell. You know, we only send them to the hospital when there's something to really gain from it. I said, yeah, but you're going bankrupt. They said, yeah, we're going bankrupt. We have to build a 12-bed unit in order to get the state of New York to rebase our payment. So here's a 300-bed facility building a 12-bed unit to play the game of getting their payment reimbursed. I mean, how crazy is this? We've heard a number of examples of craziness here today. You know, the ramp in the front. I mean, come on, you know. But so the question is not, is there anything that might make this better? The question is, what can we do now and in the near future that would make it different? What would make it possible to live with serious illness and associated disabilities, live a life that is as meaningful and comfortable as possible at a cost that the community can sustain, that the family can sustain, and that the government can sustain. We can't bankrupt everybody, but we also can't just walk away and let large numbers of people go without food, without housing, without shelter, and without decent medical care. So we have talked with about, I think Judy and I talked with 8 or 9 prior commissioners and people in public life with a lot of familiarity with policy. And this crew is quite committed to serious change. So I'm going to turn it over to them as soon as I do a brief introduction. So Kathy Greenlee, here, the closest person, is the Vice President of Aging and Health Policy at the Center for Practical Bioethics. She works on advanced directives, end-of-life planning, healthcare reform, and especially, as you've already heard, raising awareness about elder abuse. She's worked on programs and policies at every level and worked closely with disabilities and LGBT communities to improve access to community-based, culturally competent services. She had a 25-year career in public service and was the most recent past administrator of the Administration for Community Living. So Bruce Vladeck, next to her, currently serves as a senior advisor to the Greater New York Hospital Association and to Live on New York, as a consultant to a number of other healthcare organizations, and chairs the Medicare Rights Center and serves on the board of Penn Medicine. He has served in multiple important positions, including the administrator of the Healthcare Financing Administration. So you can tell it was a little while ago because it's been renamed. And Gail Walensky is an economist and senior fellow at Project Hope, an International Health Foundation, directed the Medicare and Medicaid programs from 1990 to 92, and served the White House as a senior health and welfare advisor to President G.H.W. Bush. Also from 1997 to 2001, chaired the Medicare Payment Advisory Commission and chaired one of its predecessor commissions, the Physician Payment Review Commission. So we have people who are used to making policy, and the key question to them, first off, is any comment they want to make on these, but then each of them will weigh in as to what they think we should be doing, and then we'll have an open conversation. So I want Bruce to start us off. Go ahead, Bruce.